Cancer Therapeutics, organized by Chang'an Medical Foundation and Taiwan Advanced Medical Center. I'm Ann, your MC for today. At today's forum, we will take a step into the future of oncology, discover the latest advances in precision oncology and innovative cancer therapies as leading experts from Malaysia and Taiwan gather for an inspiring exchange, gain fresh clinical insights, and also explore exciting opportunities for the collaboration and stay at the forefront of personalized cancer care. And we also welcome our partners who joined us online as well. So first, I would like to invite Professor Zhang Wenzhen, our Director of Hematology Oncology, specializing in immunotherapy for lung and urologic cancers. He will address advances in cancer treatment, precision oncology, and CAR-T therapy. These cutting-edge approaches from personalized treatment to immune-based therapies are transforming the way we care for cancer patients. Please join me in welcoming Professor Zhang to the stage.
Thank you, and Professor Luzeka, and Professor Xi, and distinguished guests, and also fellows and colleagues online. It's my great honor to be here to share with you some of our thoughts and some of my ideas regarding to the anti-cancer therapy and also some advance in precision oncology and immunotherapy, especially cell therapy, especially CAR-T therapy, which we can offer from Linkou Chang'an Memorial Hospital in Taiwan. Okay, and as we all know, previously, or some 20, 30, or 40 years ago, we have been using chemotherapy as the major treatment modality for our patients. But since year 2000, we have targeted therapies developed already, and later on, we have immunotherapy in advance now that is being widely used as in checkpoint inhibitors immunotherapy. As we all know, for a successful targeted therapy, we need to have defined the appropriate receptor and know the signal transduction pathway to block it. And for immunotherapy, we have to be aware about the cell-to-cell or immunocyte-to-tumor cell interactions, how a cancer cell was killed by our immunity. And there was an immune cell cycle back in 2023, but now there was a new one showing that other factors such as microenvironment was very, very important as well. For a successful immune killing, we must have an appropriate molecules and also the microenvironment to achieve its immune killing effect. And CAR-T was a very successful model in this aspect. Back in year 2000, we started to use the gefitinib as a targeted therapy. But at that time, we don't know why somebody has a good response, but somebody's did not. Until we found a mutation in the EGFR TK domain, and we have a good TK inhibitor to inhibit the signal transduction. As a result, the tumor can shrink within a short period of time, yet the patient will not have the side effect of traditional chemotherapies at that time. And now we have a lot of newer agents already. And this is one of my early patients who achieved a very beautiful tumor response, and the gene was sequenced. And it turned out to be an exon 19 deletion, which, as you can see here, there were 15 nucleotides lost already. As a result, the nucleotide was AA, and then followed by AA, CCA again. So this was one of a few cases from my beginning. And the other case was a L858R mutation on the exon 21, which was a point mutation, which was from A to G already. And from the beginning, she was treated with chemotherapy, but a failure of chemotherapy was seen. But after only a month of TKI, the tumor has a quick response again. And this is a particular case who was sent to another hospital with a severe multiple lung metastasis, and patient was in a very severe dysphonic condition. And his daughter has brought to my clinic. And after we sequenced the data showing the EGFR exon 19 deletion, within a few weeks, he turned to be very well and able to walk by himself. And the daughter told me that he was brushing his teeth and in the meantime was whistling, blowing a whistle, because which I cannot imagine how he did it. But very happy that he played very well after only a few weeks. So that was a surprising targeted therapy, the beginning of the targeted therapy. And as we sequenced this DNA, especially the TK domain, we can see there's an A loop, activation loop of this EGFR molecule, especially the TK domain, which was a very important site for this EGFR to be activated. When there is a signal coming down from the ligand and the receptor conjugation, the activation loop will open, and then ATP will come in and activate the downstream sequencing. But when the patient has an L858R mutation, this activation loop will open because of conformation change by itself. So as a result, the ATP will come all the way in continuously, and therefore an auto-phosphorylation will be seen, and the signal will not be stopped anymore, even without a ligand conjugation. And also another very commonly seen mutation was in exon 19 deletion, leading to a 5 amino acids delete, and as a conformation change, the activation loop will open again. And also at that time, back in 2004, people also found that the G719 mutation is also has an impact on the activation loop. And as a result, these are all called activation mutation. And we can use a TKI. The TKI is an inhibitor which conjugated to this area, which in turn block the combination, the conjugation of ATP to which prohibit this molecule from phosphorylation. As a result, the signal transduction was stopped right away. And because of this cancer cell has already depend on this mutation, depend on this pathway, so when you block it, it will shrink, the cell will die right away. This is so-called an oncogenic shock. So when you are addicted to some drug, then when we took it away, then you will die. So this is so-called an oncogenic shock. So with the oncogenic shock mechanism, we can achieve a very, very good response to the TKIs when you can find the mutation area. And after the long time of the TKI, we have started to use the third generation TKI or Tagrisso. So in the FLORA trial, Tagrisso or osimertinib has proven to be better than first or second generation TKIs in terms of the first generation or second generation, in terms of the progression-free and overall survival. So osimertinib is now and standard first-line treatment for EGFR mutated, especially in common mutations already. And after FLORA trial, we have FLORA-2 trial, because we are still wondering if we can make the treatment as in the first-line setting better. So we have the chemotherapy back again. So now in FLORA-2 trials, the TKI alone or TKI plus chemotherapy has a comparisons in here, and it turned out to be a better outcome if you add chemotherapy to Tagrisso. So this is another good data for here. But in practice, we do not tend to use chemotherapy in the meantime together with the Tagrisso, because Tagrisso alone has a very good response. So even though there is a data like this, so not a lot of doctors are practicing with chemo plus osimertinib in the front line, except some high-risk group, especially for those who had brain metastasis or who the tumor is big or the tumor location seems not to be responding to TKI alone. So in that case, we will use a combination. And then when we have a good success in the late stage, such as stage 3 or stage 4, and people started to move forward to stage 3A and stage 2, even in stage 1 or stage 1B, and in an adjuvant setting when the tumor has been removed. And then it turned out to be a big success when you add Tagrisso for a total of 3 years following surgery. The hazard ratio was 0.47, 0.49 for progression and overall survival. It means that we can reduce half of the mortality or half of the progression-free tumor recurrence in an adjuvant setting. So now, after the surgery, we tend to sequence the EGFR, and we can use it. Another gene is very, okay, here is the failure mechanism of osimertinib. If we took the osimertinib as a first-line treatment, and after around 2 years, sometimes 50% of them will recur. So when the tumor recurs, we will take a second biopsy and ask what happened to the original tumors. And then there's not, a lot of them has no specific tumor or actionable genes that we can attack on. But the other 15% is a histology transformation to small cell lung cancer or squamous cell lung cancer. As a result, we need to treat according to small cell lung cancer or squamous cell lung cancer. And 6 to 10% of them has an EGFR mutation to another type of EGFRs in the EGFR pathways. And all the rest has been evade the EGFR pathway to EGFR2 or HER2 or MET or other type of genes such as RET gene, BRAF gene, or KRAS, HER2 mutation, HER2 amplification, and the CCND or CDK4. So this is a very complex treatment mutation type. So we need to sequence them and see where we are. But if you don't sequence them, the standard therapy will be MET inhibitors following the osimertinib failure. Sometimes they will add osimertinib and the MET mutations, MET-driven drugs, such as amivantamab. And now, in 2026, for lung cancer, EGFR, we have so many drugs to use, and even lazertinib plus amivantamab. And the second most common gene for lung cancer is ALK fusion. And again, we have a lot of drugs which has been used for ALK mutation. A very famous drug is alectinib, which is a very standard therapy for us right now. And for alectinib treatment in the ALEX trial, This trial was conducted 8 years ago, and then we were waiting for the overall survival because the response and the progression-free is very good. As a result, we did not see the median overall survival until this year in 2025 in ESMO, and then we finally reached the overall survival in almost 8 years, 81 months with the alectinib treatment. So this is a very, very promising breakthrough for a lung cancer. We have to, and we can treat the patient to as long as more than 8 years. So this is a very promising treatment with the NGS, with the gene, with the targeted therapy. And another update is for the HER2 mutation and the HER2 TKIs in the BIMIAN trial with zongertinib, which is another big success right now in the second-line setting. And for first time, the trials are conducting. And we believe that it will be another big success again. So for HER2, there will be some new drugs that we can use. So for NCCN guidelines, it is required to test so many genes in an adenocarcinoma or large cell. But even with squamous cell, which was believed don't bear a EGFR or other mutation, but we still have to do all these biomarkers because the small sample of the lung biopsy cannot totally exclude the presence of adenocarcinoma in a mixed type of pathology. So in some cases, such as Asian female adenocarcinoma never smoker, if the patient meets such a phenotype, we have to consider whether this is a true squamous cell or true squamous only lung cancer, or it is a mixed type. As a result, we need to do the gene test, especially NGS test, to see where we are and to see if we can use this targeted therapy to help them. In early 2000 or 2010s, we tend to assay these gene mutations one by one with single cell, such as EGFR first and ALK second, and followed by ROS or BRAF. But now we feel like that we need to do it in a group of them, in a set that make our DNA sequencing faster, smarter, and more efficient. And with the whole sequencing, we hoped that we can help understand the complex diseases and also use the genetic analysis to predict the future health outcomes and give tailored treatment using precision medicine and facilitate the better tracking by using molecular diagnosis as well. And how we do the NGS, if you can do it right here in Malaysia, just go and do it. If you want to send it to our hospital, we can accept the tumor sample instead of the patient. So send us tumor sample and we can do the sequencing for you, for the patient. And this is another gene called BRAF, which also present in lung cancer. But initially, it was noted in the melanoma patients. And this is one of my very early cases who had treatment by the BRAF inhibitors. And in 3 days, he told me that the tumor is shrinking. And at that time, I started to photo his tumor. So I'm sorry that I don't have day zero baseline data because I did not at that time expect such a fast response. So in 10 days, you can see almost, you can't see the nodules on the skin, but if you still, you can palpable, you can do it, feel it underneath the skin. So this is another very, very dramatic response. And back in GIST, which is gastrointestinal smooth muscle tumor. And when we use the traditional chemotherapy, the overall data is very grave, it's very poor. And then if you use TKI, you can see the very, very promising outcome of this data. Also, this imatinib was used for CML treatment, chronic myeloid leukemia. And at that time, the number is STI 571. And the abbreviation of STI was thought to be stop transplantation immediately. That was a joke. So, but that, at that time, the hematologists all feel that with this STI 571 or imatinib, we do no longer need to do the transplantation anymore. And therefore, they call it stop transplantation immediately for the STI as a short abbreviation. But it's true that for CML, we can take, imagine now, newer drugs for CML already for a very, very long time. And now we are studying to use the so-called tumor agnostic targeted therapy now. It means that we don't care what type of cancer the patient have, as long as there are gene mutations such as BRAF V600 or RET mutation or NTRK, or there is a high tumor mutation burden or MSI high. We can use immunotherapy for these groups and for targeted therapies for this group. In the other, the brain tumor, head and neck, breast cancer, hepatobiliary, other GIs, skin cancer, lung cancers, colon cancers. As long as you can find the corresponding biomarkers, we can use the corresponding drugs for them. So the paradigm has shifted for earlier chemotherapy to kill every cell, including cancer cell and the normal cell. And we do it by weighing the toxicity and the clinical benefit. And to the targeted therapy to find the specific gene-specific target and give them the drugs to target the cancer cell only and sparing the normal cells. And now we use the tumor agnostic concept. We can assay every kind of tumor, and as long as we can find a specific gene, we will use the same drug. So this is a very helpful concept for us. When we are running out of the bullets, running out of the modalities to treat the patients, we can consider doing an NGS to find other gene mutations that we can attack them. So these are the drugs for NTRK inhibitors. If there is an MSI high or DMMR or tumor mutation burden high, we can use PD-1 or PD-L1 inhibitors, and also the DMMR or BRAF, RET, HER2. A lot of tumor agnostic markers that we can find already, and we can use these drugs to treat them. In the late line, but with more studies that have been published, we are trying to move these targeted therapies to early treatment, such as DMMR or MSI high in colon cancer, so in other cancers, or in triple-negative breast cancers as well. Okay, so FDA has already approved such a concept, such a treatment since 2017. Approved pembrolizumab for DMMR or MSI high cancers, and also the 2018 for NTRK, and also for the other genes, MSI high for TOSA, and also for RET mutation in 2022. And now I believe more and more tumor agnostic drugs will be approved. So we changed the gear to the CAR-T for immunotherapy, and I would like to use CAR-T as an example to introduce the immunotherapy. For immunotherapy, we are very familiar with the antibodies such as PD-1, PD-L1 antibodies, but these are cell therapies. With cell therapy, we can also kill tumor cells. As an example, CAR-T we will take blood from the patient's body and cultivate them and do a gene engineer. We put all the ingredients, all the components that immunocyte needs to kill a cancer cell. So we put all kinds of components in it and cultivate them and have a lot of CAR T cells and infuse them back to the patient only one time. And this is the first case, Emily, who is a very famous little girl to now a lady already. So, and as an example, we use hematology malignancy, but now solid tumors, especially brain tumors, is a successful example for CAR T already. And pancreatic cancer are under investigation. So we look at the DLBCL or diffuse large B-cell lymphoma or ALL, acute lymphoblastic leukemia. And there are a lot of patients who can be cured by first-line treatment for DLBCL or ALL, but there are still 20 to 50% of DLBCL or 10 to 15% of ALL will fail the first-line treatment. At that time, maybe you need a bone marrow transplantation or even worse outcome for them. But for CAR T therapy, this is the first CAR T or Kymriah or Tisa-cel. Tisa-cel, as a result, the overall response rate is 50% and the long-term complete response rate is 40%. And the second generations, other new modalities give us even higher, 73, 82% of overall response rate and 10% more of complete response. And these are likely to be cured in this setting. And we can see the progression-free and overall survival with Tisa-cel is around 30 to 40% of progression-free and overall survival. You can see a clear plateau after a certain time. And with the newer cell therapy, the outcome is better, even up to 50%. And now we have Tisa-cel in Taiwan, and we are going to have another one very soon. And in the ELINA trial in ALL, again, in a short period of time observation, in month 6, the overall survival is 90%, and in 12 months, it's 76% of the overall survival. So when, if we want to treat any patients in Malaysia, we have to send, you have to send the patient to Taiwan, and we need to collect the data when the first hospitalization using leukapheresis for the cell collection. And then after that, he or she can return home, and we will send these cells to a CAR T company, and they will make the gene engineer for us. Around 4 weeks later, when the cells are ready, and we'll have the patient to come back for the rehospitalization and do a 3 to 4 days of lymphodepletion chemotherapy to kill the Treg or other immunosuppressive cells with the lymphodepletion chemotherapy. And after that, we give the CAR T reinfusion. And after 1 or 2 weeks observation, we can send the patient home. And this is our team. And with our limited cases, we are observing the similar therapeutic outcomes in Taiwan. And we, if any patients has the need, you can contact us. We can make this arrangement for the patient. Okay, I will stop here. And thank you for your attention. Thank you.
Thank you, Professor John, for his insightful presentation. At this time, we would like to open the floor to any questions from the audiences, if you have any. Please raise your hand if you want to ask.
Thank you. You gave a very good talk, very clear. Just want to ask, I did read about CAR therapy. Actually, what is the success rate is being quoted in different numbers. What is the success rate of CAR T cell therapy?
For CAR T therapy,
Yeah.
it depends on your setting, depends on the setting. But the one I show you is around 30 to 50% of the cell therapy, depending on what kind of cells you're using. For the first generation, it's T cell, it's around 30%. For the newer ones, it's around 50%.
And how much does it cost? Because Sunway Medical Center, they are doing it, and I attended the lecture. They charge about $500,000. If yours is cheaper, we'll send patients to you.
Yeah, that's true. It costs a lot because it's tailor-made. It's been underdeveloped for a long, long time. So it costs actually did a lot. Right. How much? I need to calculate it for you. It's $500,000. $500,000. Yeah. Yeah, $500,000.
Because you're using the FDA-approved CAR T, right? You're using the
Yes, Kimraya only right now.
you can get the ones from China, which is not
That's true. That's true. Because everyone can develop their own CAR T, and if we can do it on our own by ourselves, I think the cost will down, will go lower. And now, but however, it's not FDA approved. So if you want to do the FDA approved, you have to send them to either Novartis or other Kite. There are a lot of. But actually, this is a good concept. I personally, I believe this is not only a good drug, but also it proves a good concept that using immunotherapy or immune cells that is surely can lead to a cure with only one shot. That's very, very important concept.
Just to tickle you a bit, Professor John, if you have a patient, adjuvant lung on osimertinib, develops brain mets, how are you going to manage that?
A patient with EGFR mutation and brain metastasis from the beginning?
No.
After osimertinib failure?
No, on osimertinib post-resection. Post-resection adjuvant, you use osimertinib for 3 years, I suppose, in Taiwan, don't you? And then develops brain mets. How would you approach this?
That was very sad. Is the brain the only site of recurrence?
Yeah.
Okay, then we do a surgery.
Surgery.
If we do a surgery for a solitary, I will do that, and followed by radiotherapy.
So what about doing liquid biopsy, next generation sequencing, looking for agnostic markers?
Yeah, it depends on how long did the tumor recur. Right immediate after 3 years or after like 5 years or 10 years later. If it's just right after the development of the, when you discontinue the osimertinib and it recurs immediately within 6 months, then I would doubt whether osimertinib is still working or not. Definitely I would doubt, and I will resequencing them. But if it recurred like 5 years later, then I think maybe Tagrisso is still active for this patient. So for this, if this case is from the beginning, he has a brain metastasis along with other systemic recurrence, and I would definitely use the osimertinib plus chemotherapy as the first line. But now there's another trial showing that lazertinib plus amivantamab is better than osimertinib alone. So that is another choice.
Okay, so but a bit more I would like to. You see the current situation. Iresa Tasiwa came in early 2000, right? Iresa and Tasiwa, the first generation of
Iresa,
TKI.
yeah, it's early 2000.
Now we have to use osimertinib as upfront for those exon 19 mutation.
Sure,
What
everybody do that.
happens? What would you do in your clinic when you have a patient who has relapsed with osimertinib, do you put them on chemotherapy, or would you go and try what you call gefitinib or Tarceva?
Yeah, thank you for this. Is a very, very important question, and a lot of patients are having such a problem. They fail the first line upfront, the osimertinib. So that I just show a diagram showing the resistance mechanisms of them. So if there is a chance, I will resequence them and see what type of the resistance mechanism it is and do it according to this mutation sequencing. And there is a very specific situation which is C797S mutation plus T790. In that case, maybe, C797 mutation plus initial 19 deletion or L858R without T790. Then sometimes we can use the original Iressa or erlotinib. It will work again. Because C797C without mutation, C797C, the intact of the cystine is very important for osimertinib to conjugate, to bind, to block this molecule. If it mutates from C to S, then the osimertinib will no longer be able to bind to this binding pocket. Then the osimertinib will definitely in vain. But because of the conjugation site, the Iressa or Tarceva may be able to get into the pocket without the T790 mutation. If there is a T790 mutation, then Iressa, Tarceva is out. They will be no longer effective.
So,
any other comments? Or otherwise, thank you very much again. Thank you.
So moving on to our next topic, please invite Professor Dr. Simi Hong, an esteemed senior lecturer at the University of Malaya and a dedicated consultant oncoplastic breast surgeon at UMMC. So Professor Dr. C will be exploring MIS in breast cancer treatment, a Malaysia experience. Minimally invasive surgery has become an important approach in breast cancer care, offering patients faster recovery and improved outcomes. Today, we have the opportunity to learn directly from Malaysia's clinical experience and advancements in this field. Please join me in welcoming Professor C.
这个吗？这样子啊，然后这个是 point 这边。Okay. Good afternoon, everybody. First of all, I would like to thank the organizing committee and organizing team for the invitation, and as well as my team from University Malaya Internationalization Unit. Yeah, so they are not here, but I can see few of my colleagues here. Yeah, so today I'm going to share our experience on this minimally invasive breast cancer surgery. Of course, like just now we are talking about cellular level of treatment for cancer. So we move out from there and go to our physical type of treatment and see whether any new advances in breast surgery. Yeah. So this is my little experience in Malaysia. Yeah. So I have no conflict of interest. So what we can see here from the past, breast cancer actually traditionally we need to remove the whole breast and then also the axillary side so that we call it clear from all the tumor. Then only we move to all the adjuvant treatment in the past. But of course, when we remove the whole breast, we know a lot of morbidity as well as patients do have a lot of scarring issue, pain, post-op pain, chronic pain that they will come to you every year. And you will follow up them for years, like more than 30 years, 50 years when they survive more than that. Because breast cancer is the most, luckiest type of cancer that you can survive because so many treatment nowadays, new treatment, and even we have targeted, we have PDL, we have immunotherapy, all that. So with that, we always see all these problems in our clinic. So we can see they always, actually, when they survive, it's good for the family and as well as them, but living with a lot of scar and a lot of pain is not a joke. So from there, we have moved on further to think how to make them survive more happily and then with a good quality of life. Yeah. So it's not myself thinking of all this treatment, but we think together. We always think of new things between all the surgeons in Asian region as well as others. Yeah, I'm so lucky to work together with Dr. Lai from Taiwan as well as a Singapore doctor, Dr. Mok. So we have been working and tireless, and I learned a lot from him, and we have moved on to other types of technique to treat the cancer actually, yeah? Okay, so from here you can see when we do a mastectomy, the whole scar can be very obvious in front of the chest wall, and for radical mastectomy, we have to remove all the muscle as well, remaining the bones, yeah, and the skin. So when we move on to the new technique after the radical, because a lot of morbidity, patients have very painful chest wall, skin, as well as their hand. The movement of the hand also have problem. So after that, a new technique called modified radical mastectomy was started many years ago, and remaining all the muscle and don't remove them at all, but yet the scar is still very big. So with that, we have moved on to thinking of, can we reduce the scar? Can we even make the scar, what we call totally hide the scar? So that's really possible if the cancer is early cancer and not the locally advanced disease, yeah? So with that, our cancer screening is getting better and better. A lot of screening centers have bring us a lot of new early breast cancer. So we can move on to other types of surgery that preserving the skin, nipple, as well as hide the scar away from the wound. But then let us think about it, because human hand is always, you know, as a surgeon, you know how far you can go, how much you can turn your finger around to get the tumor out. But to remove the whole breast is not easy. So because of that, we have moved on to other technique to help ourselves actually, not even though we are saying that we help the patient, but of course we know it's helping the surgeon, the new technique using other gadget, yeah? Okay, to look at that, what is endoscopic surgery in breast cancer? Because endoscopic means you need to use a scope with a camera in front of you, helping you to visualize clearly what is the thing that you are going to dissect, what is the thing that you are going to remove and preserve, yeah? So all these things is very important because the new era of technique advances in medical health actually is moving to more and more advanced gadget, but of course we know the cost is higher to everybody as well as the patient. But looking at the cost as well as what is the outcome they're going to bring to patient in their next 20 and 50 years of life, I think we are looking at more cost that not direct cost sometimes, you know. So we have made some changes and a lot of debate on the cost, of course, on this new gadget, but looking at the future as well as the chronic and what we call, longer terms of cost calculating, of course, the minimally invasive surgery have moved and make better for our patient, yeah? So talking about endoscopy, so we need to find a strategic incision to hide the scar actually. How are we going to move from somewhere that you can hide totally, people cannot see, to remove the whole breast, yeah? So I'm going to show you the next, because the core benefit of this is we are trying to preserve the skin and nipple, and at the same time we want to make sure the nipple sensation and as well as the necrosis is reduced as much as we can, right? So moving from there, we can see what is the outcome and evidence that's showing. Is it a very safe procedure? From now, actually all the evidence has matured and the data has supported that there's long-term study and systematic review talking about this minimally invasive surgery for breast cancer treatment, yeah? So they are stronger and stronger now as compared to maybe 10 years ago, yeah? So looking at this, from this endoscopic breast cancer surgery, you can see the margin positive, how high is the margin positive as compared to others, yeah? So we do have some margin positivity here, you can see. And what about recurrence, yeah? So from the recurrence itself, very low, you can see here, yeah? So margin positivity in this breast conserving surgery endoscopically, we do have some, yeah? So what about mastectomy? So this endoscopic nipple mastectomy systematic review, you can see very low margin positivity, 1 case among 20, 2 case among 25. This is the early result from the researcher, you know, the surgeon. But moving down, the cases is more and more, 200, and then only 1.1% margin positivity using the endoscopic way. And what about local recurrence? It's even lower as compared to what we can see. 5.9% is the highest, and in the 24 cases, and 1.1% in 282 cases. So death itself is low as well as compared to what we can see, mastectomy, death, because they are early breast cancer, of course, the death is very, very low, yeah? So the indication for endoscopic breast surgery, we also have to be very careful in choosing the patient because not everybody is suitable, especially those tumor is very superficial or deep, invading the muscle, locally advanced disease, or that is not suitable for this procedure, yeah? So we hope we can get all this very early type of cancer or benign disease or prophylactic mastectomy, yeah? So indication is, can see here, T1 away, 2 centimeter away from the tumor, favorable tumor to breast ratio, and if the tumor is multicentric, you can't save the breast anymore, you can't do any breast conserving surgery, yeah? And those who have done the most neoadjuvant chemotherapy, pre-neoadjuvant is not T4B, then suitable, yeah? Contraindication, locally advanced, large breast size, which is like even, generally we only advocate the size about maybe about 500, 600 maximum. But of course, people can do even bigger breasts, but we need to bear in mind, during the inflation of the gas, the skin flap do expand, and then you have difficulty to access the most inner area of the breast. So we don't advocate a bigger breast to use this endoscopic technique, yeah? Okay, the type of technique we can use gasless without any CO2 or with inflation, and we have multi-ports and single ports. Okay, you can see here, gasless technique, you only use the scope. With a small incision, you move into the area and dissect. Multi-port, you can use a multi-scope. And finally, single port, which is the latest one, yeah? Okay, so preparation exactly the same when we do a nipple sparing mastectomy. Make sure the tumor imaging all being seen, reviewed together with your radiologist, and it's safe to proceed. And we need to map tumor if possible during the surgery. And then we need to assess the incision, which is the best incision for the patient when patient in the sitting position. And patient do understand where is the location of the incision. Are they happy with that? You know, you can choose either axillary or lateral chest wall, yeah? Okay, so you can see here the scar that we use, either axillary or lateral chest wall. Okay, so this is an instrument that we use, 30-degree scope, and hope we can get 3D scope camera is the best. Even HD, 4K also possible. And other things is like laparoscopic set, bipolar energy devices, with a good smoke evacuator, or sometimes we do implement or in what we call innovated other devices, like using the feeding tube on the Maryland to take out the gas as well at the same time. Yeah, okay. This is our 2D endoscope instrument, and this is a 3D endoscope instrument. Yeah, not very complicated. Yeah, okay. So other drug that we use, like tumorsen, we need to what we call dissect out the plane before we put in the scope. So normally we use adrenaline, lignocaine to reduce the pain post-op, and as well as to reduce bleeding. Yeah, and intraoperatively we do inject the methylene blue mixed with the lignocaine gel at the margin of the breast. Okay, the setting, later I will show you the video, yeah. Okay, so we started with a benign disease first before this. So you always draw the area that you want to do the resection before the surgery itself. Patient standing, then you roughly know where is the site that you are going to remove. Then with this, all this scope you will set up in the OT. So you can inject tumorsen around the nipple or at the site, yeah? So open up the lateral chest wall incision. Once you can enter the posterior plane, then you put in a scope and cut the area until you reach the inner margin, superior margin and inferior margin, yeah? So after that, you go to superficial area, yeah? So anterior resection, you can see the photo at the, up there. So the visualization in this 2D is not easy as compared to 3D. So later I'll show you the 3D one is clearer and then easier after the change of the technique after that, yeah? Okay, so we see the other one. So this one is 3D endoscopic breast surgery with immediate reconstruction, yeah? So we will start exactly the same, but this is a cancer case, yeah? So we will draw the margin that we are going to remove everything, so match everything first, because patient is going to have an implant reconstruction immediately, yeah? So we will start with the sentinel lymph nodes biopsy, because this is early breast cancer, yeah? So you can see we use a single technique using patent blue. So we'll send off the sentinel lymph nodes for frozen section at the same setting. So this is a blue gel that we are talking about to inject carefully around the margin of the resection. Then you'll enter the breast using the lateral chest wall and go into the posterior plane and open up and lift up the whole breast tissue from the posterior side. Okay, so we will inject the tumorsen to make the anterior plane clearer, yeah? Then this is a tunneling. We try to make few tunneling so that when the gas blow in, the space will open up. So you insert the port. So the 3D camera will be pointed. You can see very clear, right? All this you can see the depth as compared to the 2D just now, yeah? So posterior, you handle the posterior, then you go to anterior. The tunneling area you can see, it will open up the space for you to very clear, and then you can open up clearer and you dissect the anterior plane easily, yeah? So the dissection will go down, up, and then at the end will be the 3 or 9 o'clock area, yeah? Yep. Okay, this is the last part. And you can see some vessel at the 9 o'clock area there, the internal memory that perforate to our chest wall. Then you remove the breast from the incision that you made normally about 5 centimeter, yeah? Okay. So some of the fat is being dissolved by our tumescent. So you can see not like a round fat type of breast normally, yeah? So after that, you wash and we will put in the implant there and then open up the plane that normally we do retro memory because we don't have what we call ADM over in Malaysia, yeah? So implant will be inserted, retro memory, and sit up the patient to match whether both sides is quite equal after surgery, yeah. Okay, so we'll match using other measurement as well so that more objective, yeah. Apart from eyeballing, we use the suture as well as the measuring between the normal breast as well as the reconstructed breast. Yeah. Okay, so drain will be inserted and then we'll close the pocket for our implant as well as the whole breast. And the wound is only at the side of the chest wall. A bit dangerous, putting the finger like that. Have to be very confident if you do that. So we only use the instrument to push the implant in. Okay, the wound is very small, but can be assessed by the scope for the whole breast. I think it's very, very interesting to everybody and a good news for our patient actually. Yeah. So after surgery, they will weigh off the wound, yeah? So another one is without any reconstruction like just now, but we don't put a implant or any flap inside, and patient still having a nice contour of a skin flap as well as a nipple is still there, yeah? So the technique is very helpful to a lot of people nowadays, yeah? So we move on. So the learning curve is another question that always being asked by a lot of people. So far, what we can find is about 15 cases, yeah? But of course, what we say is it really depends on individual, yeah? So those who already used to the technique in 2D, when they move to 3D, then it's even like lesser cases, like about 5 cases, you're already used to that, yeah? And a lot of challenges because you really need to appreciate the flap thickness, you know, maintain the thickness everywhere when you cut. Hemostasis is another thing that because you are going through a small hole and then you need to make sure everywhere is no bleeding after surgery, yeah. So it's not easy, but of course we have a technique that have to ask your anesthetist to increase the BP after your surgery. Make sure you can see all the bleeders that are shooting, then you can stop them. Otherwise, so far we don't have too much of bleeding after surgery, yeah. So, but having said that, the importance of simulation training as well as the mentorship and proctorship is very important, yeah. So looking at this study, you can see learning curve. This study was started when the endoscopic technique was started. So it's very early phase, then they found out it's about 15 cases, yeah, in Taiwan. And also here, also about 15 cases, yeah. And we also have a bigger study and meta-analysis looking at what is the post-op outcome of MIS versus conventional nipple-sparing mastectomy. Yeah, and you can see MIS exhibit a longer operation. Yeah, of course we know you have to go through a smaller incision. When you average all the procedure timing, you do need a little bit longer time. Yeah, and as well as this conventional, we noted they have a shorter length of hospital stay. Yeah, from this meta-analysis. Yeah, what about blood loss? So for blood loss, both of the group, we can see MIS have reduced as compared to conventional nipple-sparing mastectomy. And oncological outcome is the one that we always looking, and we hope is, hopefully is, we can't achieve a better outcome nowadays, like, you know, our mastectomy, everything treatment is already maximized, right? So we hope the MIS always have a comparable and the same outcome, which is like what we can see here, yeah? And another thing that we are looking at, the skin necrosis as well as bleeding, yeah? So from here, nipple necrosis was significantly reduced in MIS, yeah? And implant loss, there's no different or no significant difference. And bleeding and seroma, you can see here, they are no significant difference as well, yeah? But when we talk about new technique, more advanced type of technique, we always have a lot of challenges, yeah? So higher cost is one of it because you have to acquire a new machine or any other new things from a normal conventional technique, and as well as long-term outcome do matter to everybody, I think. Because this study, this technique started 10 years ago, yeah? So about 2015, 2017, like that. So looking at that, we might need another few more years to look at the long-term outcome, yeah? And you can see here, MIS, why they help a lot in blood loss, why they help a lot in necrosis flap, necrosis nipple, all that, because you are doing a direct visualization, you know. It's not like how you do conventional, if don't even can see the vessel sometimes, yeah. So all these have improved, and we preserving a lot of area, preserving a lot of dermis plexus, do help a lot in flap ischemia, as well as the sensation, yeah. So patient do have less pain, and as well as very comfortable after surgery if you use MIS, because your scar is so small here, and they don't even have a need to wait too long for wound healing, because long wound always you need more than 2 weeks to 1 month. But this short wound, 3.5 centimeter to 5 centimeter, normally 1 week the wound will heal, yeah. And of course we know how to deal with these new techniques so that people can learn, can use it and help our patient. We need to build the capacity, train the people, mentors more surgeons to use it and train more, yeah. And what we can see here, MIS really help a lot in ergonomic, but when we see the instrument, right, all the instrument is straight, right? There's no angulation instrument. So we know those who do a lot of laparoscopic hemicolectomy, all the bowel, you know your angle always is a problem, right? When you go to the extreme angle. So we do have ergonomic issue in this endoscopic surgery, and you can see here, position, and then your angulation, your hand, and you can see my trainee, they do have problem when they help us to do the cameral assistant, yeah, okay? So we do have this problem. And because of that, robotic surgery really help, you know? So it not only helping us to go to the extreme area, but to a surgeon, it really helps us to reduce all the ergonomic issue, and you can just sitting there and operate without doing all this, lifting all your hand up, all that, yeah. Even your assistant, you can see how your assistant doing, just sitting there and helping you to adjust the robot, okay? So this is really a new what we call new technique that nowadays in breast surgery. And the precision really help us, and we are moving even to AI, artificial intelligence, in training the surgeon in future, yeah. And of course, you know, telesurgery is already a goal in China, as well as I think Taiwan is starting as well soon, yeah. Okay, so we have our first robotic surgery this year, and hopefully we can help more. Of course, you can see who is a proctor, Dr. Lai from Taiwan and Dr. Mok from Singapore, you know. So we all, regionally, we all work together. So hopefully all this can be a better outcome for our patient in Malaysia as well. Okay, so importance point for our MIS, you know, longer surgery initially, but of course it will improve, yeah. With a learning curve achieved, most of the cases will reduce to 1 hour half, you know, as compared to if you do back a small incision and conventionally you cannot achieve that normally. Yeah, a lot of new benefits, shorter hospital stay. Sometimes we even can do what we call daycare type of surgery for our patient, yeah. So patient reported is part that we are going to move on to collect, and hopefully we can get a better result in future. Okay, so in summary, we know evolution is very important to help us, to help the patient, yeah. And we are moving from more is better in breast surgery to less is more. Okay, and all this evolution have made a lot better for our patient as well as the surgeons and the doctors as well, and assistant, you know, like what we see here. Okay, so from here we know challenges and the future of MIS is, you can see a lot, right? Cost, training, technique, all that. I think refinement is there, and then a lot of people awareness of the usage and benefit have bring another height to a new breast cancer treatment in future. With that, I thank you.
Thank you, Professor Dr. C, for the enlightening presentation. We'd like to take a moment to see if there are any questions from the audience. If you have a question, please raise your hand.
Yes, Dr. C, how's the oncological outcomes when you use endoscopic?
Okay, so just now we are looking at oncological outcome in terms of recurrence and overall survival is similar, but of course we want to have a better data. So far what we have from Korea, they already have 2,000 to 3,000 patients comparing conventional and endoscopic and robotic. So it's comparable so far, yeah.
Do you consider it as a radical mastectomy or a partial mastectomy?
It's a radical, it's removing the whole breast, but we only preserve the skin, nipple, and areola complex.
So any concern about the post-op adjuvant therapy, such as radiotherapy or other kind of therapy? Are there any differences?
So far, what we can see here, radiotherapy do cause the skin fibrosis, but of course, when we have intra-op checking of the nipple base, axillary lymph nodes, if they are positive, definitely we won't put an implant there already. So it will go on to normal autologous recon, or we just put an expander so that post-op patient will go on for radiotherapy as normal. Yeah, the timing is not affected so far. Even they recover earlier compared to the conventional type. Yeah. Thank you very much. Yeah.
Thank you, Professor Dr. C. So next on, please join me in welcoming Dr. Yep Win King, our radiation oncologist from Chang'an Memorial Hospital. He focused on proton therapy for head and neck and esophageal cancers. So today he will be presenting intensity modulated proton therapy for head and neck cancer and esophageal cancer. This state-of-the-art approach enables exceptionally precise dose delivery, reducing harm to surrounding healthy tissue, and opening new treatment possibilities for patients with complex or challenging tumors. Please welcome Dr. Yap.
OK，这样子，这样会看得到。OK， Hello. OK. Yeah, good afternoon, everyone. I'm Winkin Yap from Dr. Winkin Yap from Proton and Radiation Therapy Center at Linko Changan Memorial Hospital. And today I will be presenting on the topic intensity modulated proton therapy for head, neck, and esophageal cancer. And I will specifically focus on the how this technology represents a paradigm shift in precision radiation oncology. Slide there. Okay, good. So we begin by acknowledging that the therapeutic tightrope we walk in treating this disease because while radiation therapy is a cornerstone for the cure for head neck cancer and also esophageal cancer, but we are constantly battling with the proximity of the tumor to the critical organs, such as the spinal cord, parotid glands, brainstem, and in the esophageal cancer, we have heart in front and we have lung bilaterally. So all these low dose and intermediate dose bath can cause a lot of toxicities during treatment and post-treatment, such as mucositis, dysphagia in head neck cancer treatment, and also the cardiopulmonary toxicity for the cancer, esophageal cancer treatment, which not only compromise the quality of life for the patient, but also leading to treatment interruptions. So what is the solution? And we think the solution lies in the fundamental physics of the proton. So because as you can see, this depth dose curve, proton is different from photon beams, which is X-ray, will deposit the dose all the way through the patient's body and out the body. So we have a substantial exit dose behind the tumor here, for X-ray. But proton beam, we can adjust the energy of the proton beam and let the proton stop at the tumor and then release all the energy at the spots. And after that, we have this bragg peak here. So after that, there is no exit dose behind the tumor. So we can spare the patient from all the low and intermediate dose bath. So I will like to use this slide to make some nomenclature clarification here. So if you see my slides appear to have this blah blah RT, means that it is X-ray, it is the conventional photon therapy. But if you see the slide have blah blah PT, means proton therapy. So we will keep in mind this difference. So because there are so many terms for radiotherapy, IMRT, VMAT, photon therapy, everything, no PT means X-ray. Everything with PT means proton therapy, okay? So by visualizing the slides, we can see the very different dosimetric for the head and neck cancer treatment. For the parotid gland, we only want to radiate unilaterally. So if we use proton, we can spare the contralateral dose to the contralateral organ at risk. And for the MPC patient, you see this is the proton plan and this is the photon plan and this is the subtraction. So all these dose here can be spared if you use proton therapy compared to photon therapy. So much of the low dose bath to the oral cavity and also the brainstem can be spared. So if you look at these two pictures here, the above one is proton therapy plan and the below one is the IMRT plan. So you can see the proton stop here, so the mucositis stop here also, a very distinct line you can see. But for the photon therapy, X-ray therapy, depends on your normal tissue tolerance. So some patient, if you can tolerate high dose, you can get also similar side effect. The side effects stop here. But for some patient, malnutrition, old age, you have hard time to repair your damage. The mucositis can be widespread. So you cannot predict where the mucositis stop for photon therapy. So now, how can we translate this benefit into measurable clinical benefits? So we have to look at the data. So this is the retrospective propensity score match analysis from our hospital, Lincoln Changan Memorial Hospital, published in 2021, the first study comparing proton to photon therapy in NPC published. So we find that we can reduce the NG tube placement during the treatment and also reduce the weight loss during treatment. And also numerically, you can see the grade 3 mucositis rate is lower also, but this is not statistically significant. So Memorial Sloan Kettering Cancer Center also published their data. After we published our data, they also published in 2021 also the same propensity score match analysis of their cohort comparing proton therapy and also to the VMAT. They also find similar similar result, which proton therapy can reduce grade 2 plus acute adverse effect. So systemic review also find a similar conclusion. Proton therapy compared to photon therapy can reduce grade 3 mucositis and also feeding tube placement. So beyond clinician-graded toxicity, we must also consider the patient's voice. So in 2025, this year, Changan Memorial Hospitals also published our data on the patient-reported outcome in NPC. We also find that on patient-reported outcome, we found that distress scores for oral ulcer and also the difficulty opening mouth were significantly lower for IMPT or proton therapy compared to VMAT. So with the greatest benefit observed during the treatment at 7 weeks, which is approaching the end of the treatment, the most severe toxicity timeline, right? So we are confident to say that for head and neck cancer, proton therapy can reduce acute toxicity for the patients. So crucially, this toxicity reduction dose does not come at cost of efficacy. If you look at the oncological outcome, our own data, Lincoln Changan Memorial Hospital, this one is from Memorial Sloan Kettering Cancer Center, and this one is for our multi-center Changan Research Database, which is collecting all the data from our branches across the Taiwan country. So look at all this data, we find that IMPT have a comparable outcome to IMRT, and if not better. So you look at all the proton line is above the VMAT line on survival and also progression-free survival. So this is the first phase 3 randomized trial, which was just published 2 days ago on locally advanced oropharyngeal cancer, comparing IMPT to VMAT. So by Professor Frank from MD Anderson, we congratulate him for conducting this phase 3 trial. This was a non-inferiority trial comparing VMAT to IMPT. 440 patients met the primary endpoint. So the progression-free survival is non-inferior and also reducing acute toxicity. What is very interesting is that this trial found overall survival improvement for proton therapy a 10% overall survival improvement. This is what very interesting here. So, but why is the PFS similar, comparable, but better OS? I think this comes from the reduction of toxicities. So in their trial, they found there is an absolute reduction risk of 13% for the G-tube dependence and during treatment and post-treatment, within 90 days post-treatment, and they reduce the dysphagia, dry mouth, and also severe lymphopenia. This severe lymphopenia is very important for tumor control and long-term survival. So they found also there is fewer treatment-related death and also post-progression death for proton therapy. So, which means that these patients, if they treat with proton, if they recur, they have better survival, right? If you treat with proton, if you recur, you have worse survival. It means that the first initial treatment affect the outcome for the salvage treatment. So we also, when we treat a cancer, we always think beyond the first treatment because some patients, they experience recurrence, so we have to consider the salvage treatment outcome also. So now we shift gear to esophageal cancer. So this is the dosimetric advantage we can see in IMPT for esophageal cancer. So this is the VMAT plan. This is the proton therapy plan, but it's passive scattering, which is the old technique. Now in Chang'an, we all use intensity modulated proton therapy here. So comparing these three type of treatment, we can see that IMPT perform best in the mean heart dose, lowest mean heart dose, lowest mean lung dose, and lowest mean liver dose. So how to translate this dosimetry into clinical outcome, okay? So this is the MD Anderson also, from MD Anderson also, a phase 2B randomized control trial comparing IMPT to IMRT, 50 gray, CCRT, followed by resection at discretion of surgeon. So half of the this trial, I think 50% of the patient receive surgery after CRT, and 50% of them receive definitive CRT, which means they don't receive any surgery post CRT. So what they found is that this is a positive trial, so they have a core primary endpoint, look at the PFS and also total toxicity burden. So they met the primary endpoint. They show that there will be a 2.3-fold lower mean total toxicity for proton therapy. These are for both surgery group and also non-surgery group. Proton therapy have a lower toxicity, overall toxicity. For post-op complication, for the 50% patient that underwent surgery after the initial CRT, proton therapy patients have a 7.6-fold lower post-op complication. You can look at the complication rate for the pulmonary complication here. For the IMRT group, there is a 46%, and compared to proton group, only 7%. And for cardiac complication, 21% for IMRT, and only 8% for proton beam therapy. So reducing the dose to the lung and heart during radiation clearly pays off during the surgical recovery here. So again, safety did not compromise efficacy. The 3-year progression-free survival and overall survival rate were virtually identical between two arms. So proton beam, according to this randomized phase 2 trial, proton beam provide a substantial improvement in the therapeutic ratio, same cancer control, but significantly less toxicity. But does the story end here? Of course, no. Right? Of course not. So because in the randomized trial, we only include all the healthy patients, right? For those old patients and for those with cardiac event surgery, history of many comorbidities, we all exclude them out. So we need real-world data to answer the question whether those frail patients have benefits treating with proton or not. So this is real-world data. Also, MD Anderson Group, they look at their hospitals' data retrospectively. 479 patients with esophageal cancer treated with radiotherapy. The median follow-up is 76 months. They found that severe cardiac events after radiotherapy for esophageal cancer are actually common, early, and predictable. So 1 out of 5 patients experience a grade 3 plus cardiac event after radiotherapy. And the median onset time is only 7 months post-radiotherapy. So, and then 81% of them actually occur within 2 years. So the strongest predictor for these cardiac event, severe cardiac event is actually pre-existing cardiac disease. So these patients with pre-existing cardiac disease usually are excluded from randomized control trials. So you see, so but they also found that radiation modality and dose are critical factor. So compared to IMRT to proton beam therapy, IMRT has a higher mean heart dose, of course. Proton therapy can lower the heart dose, mean heart dose, and also proton therapy can cut half the grade 3 plus cardiac event rate. So from 80% to 11%, statistically significant. So, and does this then these severe cardiac events also tie with the worst survival? You can see with a patient with cardiac event, right? The survival, the 2-year-old survival only 38%, and for the patient without grade 3 plus cardiac event, the OS for 2 years is 52% here. So in this study also, they found a new threshold for heart when we do the radiotherapy planning. We want to keep the mean heart dose lower than 50 gray, which is sometimes impossible if you treat with IMRT. But if you use proton therapy to treat, this constraint is easily achievable. So also for the high-risk patient, which means that patient with pre-existing cardiac disease or proton therapy can lower the risk for this cardiac event, right? So you see 30% versus 11%. So another meta-analysis shows us that in real world, if you use meta-analysis, we look at the real-world data, proton therapy actually associated with increased survival. Hazard ratio for the IMRT is 1.4, which means that IMRT carries a 42% higher risk of death. And also associated with progression-free survival. IMRT have a 48% higher risk for disease progression. Because this is real-world data, we have a lot of high-risk and frail patients in this real-world data. And so we can see the maximum benefit from proton therapy in esophageal cancer treatment. So the meta-analysis also shows us that proton therapy can reduce almost 10 gray of heart dose, mean heart dose, and also 5 gray of lung dose. So, and clinically, proton therapy can reduce severe lymphocytopenia and also reduce pericardial effusion and radiation pneumonitis, reducing all the toxicity. And this lymphopenia here is very important, and I think it is a major cause for the lower disease control in IMRT and also the lower survival in IMRT. So why is lymphopenia so important? So perhaps this is a very important emerging concept, which is called the immune-sparing radiotherapy, because now we are in immunotherapy area, so everything has to be associated with immune system to be trendy. So we have this immune-sparing therapy. So For MRT, we have this low-dose bath. So you can see the blood pool inside our circulation blood. There's so many lymphocytes here. They are very sensitive to radiation therapy. So all this low-dose bath can actually kill the lymphocytes. But for MPT, our dose only restricted in the area of treatment, no low-dose bath, so we can spare all the circulating lymphocytes. So retrospective studies have shown us that proton therapies have lower incidence of lymphopenia, grade 4 lymphopenia. This is a secondary analysis of the previous phase 2B studies from MD Anderson that do a post hoc studies to look at the lymphopenia published in Red Journal last year. So they found that proton therapy has lower risk for grade 4 lymphopenia. And some of the multivariable analysis, some of the predictor here, they found induction chemotherapy can cause lymphopenia. We know that. If patients have a lower baseline absolute lymphocytes count, they can have a greater risk for lymphopenia after radiotherapy. This is making sense. And also the modality of radiation. If you use proton beam therapy, you have lower lymphopenia. And also the treatment planning volume. So the volume you treat, the larger volume you treat, the higher risk for lymphopenia. So they make a decision tree here. You can see if you have a very, very low baseline ALC, absolute lymphocyte count, you have a highest rate for lymphopenia. But if the count is not so bad, then we look at the treatment volume. If the treatment volume is big, then we look at the count again. If the count is, not so good, then you probably think twice what type of modality of radiotherapy you want to use. You can have if you use IMRT, you can have a 70% risk of lymphopenia. But if you use proton therapy, you can cut the lymphopenia risk to half, 35% here. So this group of patients with a big treatment volume, worse baseline ALC, they may gain biggest benefit from using proton therapy compared to photon therapy. So, my colleagues and I, this year we use meta-analysis, look at these hidden costs for thoracic radiotherapy, published in November last month in Green Journal. So we look at this matrix called EDIC or EDRIC, which is the estimated dose to immune cell. This is a model which first developed by Professor Jin et al. And later improved with changing the way they estimate the mean body dose. They use a new term EDRIC here, but similar calculation, similar model to estimate the dose. Estimation is estimate the dose to the immune cells in circulating blood pool. So, but you can see they integrated three important variables, which is the mean lung dose, mean heart dose, and mean body dose, which all these can be lower with proton therapy. So we collected this study have 16 studies, 4,500 patients, including 1,000 esophageal cancer patients, 3,000 plus lung cancer patients, and we found that EDRIC, as the dose to the immune cell, actually associated with increased 22.8% risk of mortality, and it also significantly associated with across all the endpoints: progression-free survival, disease-free survival, local regional-free survival, distant metastasis-free survival. So sparing the circulating lymphocyte is very important for not only for the patient toxicity, but also for the tumor control and survival. And interestingly, we do a subgroup analysis, and we found that in a patient group with a higher age, older patient, this effect is stronger because old patients, they have a weaker immune system. So it is more important to preserve their lymphocytes when you are treating old patients. And also we found that the lower cutoff actually have a stronger effect, which means that dose response relationship is happening here. So the low dose buff area, low dose buff volume is more important than the high dose area. So this part can be best preserved by proton therapy. The effect is significant for lung cancer and also esophageal cancer, of course. So why is it sparing the lymphocyte is more important now and previously? Because we are entering the era of immunotherapy. We have to preserve all our immune cells to best enhance the immunotherapy. So for esophageal cancer, for example, now the standard of care after you do a CCRT and then you do surgery resection and then look at the pathology report, there's a residual cancer in high risk, so we will add on nivolumab. Now it's becoming the standard. So before you do nivolumab, it is best for you to preserve all your lymphocytes to get best outcome out of the nivolumab. So now we are now no longer asked if proton have dosimetric superior, but how we best leverage this advantage to the patient, translating physical dosimetrically superiority to biological advantage. Thank you.
Thank you, Dr. Yep, for his wonderful presentation. So now we also open the floor for questions from the audiences. If you have any questions, please raise your hand.
Can you explain, you explained in passing, what is the old proton therapy method and the new intensity modulated therapy?
Okay, so the old, we call it passive scattering. So we use a method to broaden the beam. So we can treat a whole volume at one time, but the beam we cannot shape the volume so conformally to the tumor. But with intensity modulated proton beam therapy, we use pencil beam scanning technique. The beam is like a pencil, very sharp, and we can delineate the tumor volume layer by layer. So the high dose area is very conformal to the tumor. This is the fundamental differences between passive scattering proton beam therapy and also the pencil beam scanning IMPT.
Follow-up.
This is the first time I've heard a lecture on proton therapy. I've read about it, that Singapore have proton therapy, and you need a very long, a very big space to treat, to put a machine. Actually, what will be the cost? Let's say you treat esophageal cancer or MPC using IMRT and proton. What's the cost difference?
Roughly 3 times. Yeah. But increase 10% of overall survival for oropharyngeal cancer. So you see, we look at the studies for those big farm. The medicine is very expensive also, but the survival only increased for 3 months. Then we say, oh, very great. But for proton therapy, actually, if you really use it appropriately to the fit patient, you can gain much benefit out of the the money, extra money you pay.
How many times?
Huh? 3 times. 3 times.
3 times and the other?
What? Which is the other one?
Survival?
10% of, let me see, 10% OS for, I think, 2 years, 2-year OS, 10%. Just published 2 days ago. And yeah. No. We say, you see here, the 5-year overall survival, you have 10% more patients living beyond 5 years. 10% more patients living beyond 5 years.
You mentioned about intensity modulated therapy is
Yes.
because of the refinement in the beam.
Yes.
So this relates to the capability of the technology provider.
Yep.
So, and you have almost 10-year experience in proton therapy, one of the leading in the region.
Yes.
And I'm sure you have gone through a lot of technology provider, and your capability for doing this intensity modulated therapy is as a result of your technology provider.
Yep.
Now, can you explain to us, we laymen, we do not know about proton therapy, about your experience of working with these different technology providers, and what has been your experience?
Okay, so actually, we started to, our founders started to plan to have this proton therapy actually many years ago, 20 years ago, I think. So we from the planning to the completion of the proton therapy, I think 10-year history, right? 10-year history. So actually at the beginning, they evaluate, they think, the technology is not there yet. So they postpone. By the time we have this proton therapy, actually the technology have already reached a certain level that is safe and good for the patient. So we started with two treatment rooms with IMPT, pencil beam scanning technique, and 2 passive beam scanning room. But then later we find that most of the doctors prefer to treat patients with IMPT, of course, because more conformal. So the using rate for the other 2 rooms is lag behind. So we upgraded the one passive beam scanning room to IMPT. So now we have 3 IMPT room and 1 passive scanning room. But later we want to upgrade also the passive beam room to IMPT, because last time we want to use the passive beam for the moving target, because passive beam you treat the whole volume at instant. So when the tumor is moving, right, you treat it in whole instant, so you don't get the perfect error from the moving beam. So passive scanning beam, the beam scan move when the tumor move also. So you can have the exactly perfect error unmatched. You know what I mean? The error. Because it's very complicated because the tumor is moving, and then you want to scan the tumor, you have to track the tumor also moving. So it's very difficult. So we use the passive beam for this type of moving target. But now we have very good respiratory control. We have deep breath hold protocol and all this. We can actually minimize the tumor moving the tumor moving area, and also we have technology called rescanning. So we basically scan the tumor repeatedly, like for 3 times, 4 times, so we can smear out the uncertainty for the moving target area already. So now we think treating all these moving target with IMPT is safe, and it's in our own experience, in our own data, and also data published by other centers, it is comparable oncological outcome and also safety. Yes.
Last question. The proton therapy is also moving into using the carbon proton and hydrogen proton.
Okay.
Where are you, and what is your view of that?
So heavy ion therapy, like carbon ion, hydrogen ion, all this, we call it heavy ion. So this is very, very complicated because heavy ion, physics and the biological effect for this heavy ion to kill the cells is totally different from X-ray. But proton therapy, the mechanism of killing the cell is more comparable to X-ray. So for us, X-ray data is the basics. We know all the side effect and all this we can calculate, and the dose, changing the biological dose between different regimen, different fractionation, all this. But for heavy ion therapy, the calculation model carry a lot of uncertainty. You see, Germany have one model, and Japan have one model. So if you use different model, you can calculate and with a different result, different dose, biological dose. So there's a intrinsic, inherent uncertainty for the dose calculation. And also the building cost for ion therapy is 3 times proton therapy. So the maintenance fee also 3 times. And if you want to do a gantry for heavy ion therapy, the cost is even higher, and also the technology is even complicated. So now in Taiwan, we have one heavy ion treatment center, but they are using fixed bin, which means that they cannot move the bin. They cannot move the bin. For proton therapy, we have a 360-degree gantry. We can move the bin anywhere you want to shoot the tumor. You can find the perfect angle. So for heavy ion therapy, if you want to tweak and twist the plan, you want to find a best angle, you have to move the patient, you see. You turn the patient like this, turn the patient like that. Every day you want to do the same thing. You want to make sure the patient lies the same position every day. It's very difficult. So, and also the data, there is no clear data. Data is very limited, and no data showing that heavy ion therapy is performing better in oncological outcome terms, is better than X-ray or proton therapy, you see. So the only phase 3 data for proton therapy versus X-ray is actually this oropharyngeal cancer. We now have phase 3 data versus photon. But for heavy ion, there's no data, limited data. So there are so many difficulties, delivery, technique difficulties, all this very hard, I think. Yes.
What's the difference between proton and gamma knife?
Gamma knife is X-ray also. So proton, gamma knife, we use it for radiosurgery, right? Kill the tumor in one shot, high dose. For proton, we can do the same. We call it proton SRS, proton radiosurgery. Yeah, the gamma knife is gamma, not X-ray, gamma ray. But that is similar, it's photons. We call it photon, X-ray, gamma ray, or photons. Yeah.
So thank you, Dr. Yap, for his really insightful presentation. And now we'll be taking a 20-minute break. And so we will have refreshments outside so you can help yourself. And please come back around 4:40 in the afternoon. So we have also invited some of our Taiwanese vendors. They have their booths behind this conference room. You can go and talk with them, and they will introduce their new products to you if you're interested in. Thank you. will be giving us a topic about treatment of hepatocellular carcinoma, surgery in dendritic cell-based immunotherapy. Professor Lee will guide us through how surgical approaches paired with innovative immunotherapy techniques are creating a new possibility for improving liver cancer outcomes. Please join me in welcoming Professor Lee.
Okay, and good afternoon, ladies and gentlemen. So today I will talk about the treatment for hepatocellular carcinoma in the surgery, and also I will say about the dendritic-based immunotherapy. Okay, this figure is the BCLC Barcelona liver cancer classification. So actually, the HCC will be according to the early stage, intermediate stage, later stage, and also the terminal stage. So today I will focus on the early stage for the surgery, and also I will talk about the advanced surgery about immunotherapy and the cell-based immunotherapy. So first I will talk about the liver resection and liver transplantations. So for the liver resection, actually now can do the open surgery or microscopic surgery or even robotic assistant surgery. But no matter what, which method you choose, it's just the surgery, it's a resection of the tumor. So we have to know how the indication of liver resection. Most of the time, if the liver function is adequate, and the tumor is solitary, so the first choice will be the liver resection. And also the liver resection will limit it to the tumor just only 2 or 3, because you can do the liver resection for many tumors, but the prognosis is not very good. So actually, in our hospital now, we limit the number for the tumor within 3, then we can do the liver resection. And also, we establish a formula to calculate how the liver function is enough or not. Based on the isogreen test, then we can calculate how residual liver have to preserve to prevent the liver failure after liver resections. And also, there's our recent result. If they choose the suitable case to do the liver resection, then the 5-year survival can be around 60%, 70%. So for the liver resection, now the long-term survival about 10 years, about 40%. And then the result will be better than before. But the most important for the liver resection is that actually more than half the patient will tumor recurrence within 5 years. They have the 2 peaks of the tumor recurrence. One is within the 2 years, we call this early recurrence. This is mainly related to the tumor behaviors. Then if the second peak of the tumor recurrence will be occurs between the 4 to 5 years after liver resection, that may be related to the liver itself. So the tumor recurrence after 4 or 5 years may be not the same as the tumor you resected before. So now we use the nomogram to calculate who will be the patient and it's the highest to recurrence after liver transplantations. So this is a figure, and we calculate the score before the operation. If the patient has a high score, nomogram high score, it means it's a high instance of recurrence after transplantation. At that time, we can preserve the specimen to follow adjuvant therapy. After liver resection, based on added pathology data, we can calculate, use the nomogram score to calculate the patient who will be easy to have the tumor recurrence. Like if the data will listed here. So if the score is than 10%, 5 years, the survival rate will be more than 60%, around 60%. But if the more than 100 score, then the 5 year, the disease-free survival just only 40%. It means that 60% of the patient will recurrence after liver resection. So based on this, the score system, then we can do dendritic cell-based adjuvant therapy. I think it's a figure you may be familiar with. There's the study, a clinical trial performed by the Roche company. They use the immune checkpoint inhibitor combined with TKI to use it as adjuvant therapy to decrease the tumor recurrence. But actually, the result is failed because after 18 months after liver resection, the recurrence rate is the same. So currently in our hospital, we conducted the phase 2 dendritic cells-based clinical trials. Then, so during operation, we will preserve the tumor specimen, and after liver resection, we will culture the dendritic cells past the tumor antigen, then infusion back to the patient and to see whether this method can decrease the tumor recurrence rate. So if the tumor recurrence, how we can do? You can repeat to resect the tumor, or you can do the liver transplantations. But after liver transplantation, we call this a salvage liver transplantation. The result will be better than repeat liver resection. If repeat resection, 5 years survival about only 30%. But if they do the liver transplant, then the 5 years survival will be 80%. But there's a figure show the primary liver transplantation and salvage liver transplantations. Primary liver transplantation means the first time you see the tumor, then you transplant it. If the salvage means you first you resect the tumor, when the tumor recurrence, then you do the liver transplantation. So the result of the 5 years, 3 years, 5 years result is the same, but the true thing is not everybody tumor recurrence after liver resection can do liver transplantations because the tumor may be beyond the criteria to do liver transplantations. So in our hospital, we find who can do salvage liver transplantations, who cannot do salvage liver transplantation once upon the tumor recurrence. So if the patient have an early recurrence, it means the tumor recurrence within 2 years after liver resection, and also the tumor beyond median criteria, then for this patient, maybe lose the chance to perform salvage liver transplantations. And also the survival you can find if the patient is early recurrence and also beyond the median criteria, the result is very worse than other patients. So based on this, we want to find whose tumor will beyond the criteria when he have the tumor recurrence. So we calculated, we give there's a risk factor score, and we added the score. If the score less than 60%, then patient have recurrence, they have just 20%, 20%, the tumor will be beyond criteria. But if the Safe time is about 3 months. It's about time 5 time of the ICI. So if the patient image tumor reduced to meet the transplant criteria, we do a living donor liver transplantation for this case. So you can find the patient now he's tumor-free for a year. After receive treatment, the downstaging to the minimum criteria, we can do the liver antigen. that the stem cell dangerous cells will express a high level of cosmic molecule like CD40, CD80, 86. Also here the mature form 80, 83. So cultural system the dangerous cell can express very high level of the CD83. So it means the dangerous cell is a mature form. And so in the laboratory we can find the treatment with the imaging point, checkpoint inhibitor followed by the dangerous cells. So if the patient is suitable to do this treatment, we will schedule it to inject the immune checkpoint inhibitor 3 or 4 courses, then followed by the dangerous cells. But sometimes the patient have the severe form, the immune checkpoint related immune-related adverse effect. Well, there's a grade 3 or grade 4. There's a patient will not be suitable to the next dose of the ICI. At this time, we will afterward resect, we see the pathology can find that this tumor is a necrosis and surrounded by CD3 positive T cells and CD8 positive T cells. So this picture is very correlated to the immune reaction about the T cell were activated by the immune checkpoint inhibitor and the dangerous cells. Well, next case, we can find that they have the large tumor in the right lobe. It's about 15 centimeter in diameter, and they received 4 doses of the pembrolizumab. After the 4 courses of the immune checkpoint inhibitor, we found about 3 courses of dangerous cells, and the tumor shrink. And also, hit alpha fetoprotein well from more than 1,000 and down to about the 40. But we can still see a viable tumor here. Recently, we have acute cholecystitis. We have to resect the gallbladder. So at that time, we resect the tumor. So now he's tumor-free for half a year. So this is the result for this treatment 1 year. For advanced HCC, 1 year is 83%, and 2 years still have the 70%. So this is a sequential treatment with ICI followed by dangerous cells. It seems very good for this advanced stage HCC. Also, if we separated the patient into the stage B and stage C, we just wanted several cases for the stage B, but actually stage B, the case is better than for the stage C. So that's based on the immunotherapy. If the patient condition his immunity is still good, then we do the immune checkpoint inhibitor and the dangerous cells. The result will be better than the later stage. So for this immune-based therapy, it should be very careful. It's very important to choose the suitable tumor and when their immunity is not too bad. So currently we collect our 70 cases. If the patient have the partial response, this patient have objective response, then the 3 year, the 60, more than 60% is very good. If the patient just only minor regression, they still good for the patient, did not respond to this treatment. For the patient have the minor regression, 3 years survival still have the 27%. Also, we found that if the patient, the annular ratio is lower before the treatment, the result will be better. But currently, we still do some research for this treatment because still have many patients cannot be treated well. But in the microenvironment, they still have some cell may influence the dangerous cell and Treg or the MDSC. So we still have found some treatment for this case. But the ICI may have some effect to deplete this cell to increase the dangerous cell-based immunotherapy. So I make the conclusion that liver resection still is the most common treatment for solitary tumor if the liver function is good. And liver transplantation will be the choice when the patient has cirrhosis and HCC, but the HCC is within the criteria, then it's better to the liver transplantations. If the patient already have the adolescent stage, maybe can do the ICI with dangerous cells. Actually, dangerous cells is a cancer vaccine. Someday we still are doing the clinical trial for adjuvant therapy. Some days later, dangerous cells maybe can use a cancer vaccine to treat the patient for our various cancer patients. So I will stop here. Thank you for your attention.
Thank you, Professor Lee. So due to time constraints, the Q&A will be held after all the presentations. So next on, may we invite Dr. Zulaika Jamaluddin, Senior Lecturer and Clinical Medical Physicist at the Clinical Oncology Department from UMMC. Please, Doctor.
Okay, good afternoon, everyone. So today I just would like to present on the SFRT. So like Dr. Yap already explained to you. So when we see the word RT, it means that this is the technique of radiotherapy using the photon. So I just want to share the motivation for us to start offering SFRT technique in our center is because when we did our audit of the number of patients, cancer patient in our department, we saw that at least we have per year more than 30 cases of palliative cancer patient comes to us. So this patient comes with a big tumor, okay, and also so we are thinking of what kind of maybe advanced treatment that we can offer to this kind of patients, because we know that the technology has been advanced in terms of the photon and also proton treatment delivery, but should we stick to the standard palliative radiotherapy treatment of delivering to only 20 gray in 5 fraction to this kind of patient? So that's where starting from last year, we started to look at what are other techniques that we can offer to these kind of patients, and we came across this terminology of SFRT. So I just would like to share the theoretical concept behind this SFRT. So SFRT is spatially fractionated radiotherapy. So it is a form of RT, okay, but it's a kind of, we intentionally delivers very high and also low doses at the same time within the big tumor. And this, we can do it by alternating this region. So you can imagine that there's a big tumor, but within that tumor, there is an area of high doses and also low doses. So this refers to irradiation of only sub-volumes of the big tumor with a lethal high dose, okay? And allows for the whole tumor to receive the standard one, the 20 gray of doses. So the aim is actually within that big tumor, we want to enhance the tumor response. So I think for today we have listened to some anti-tumoral immune response. So this SFRT so it's quite shocking to us also to know that actually this SFRT actually it can help to enhance this bystander effect, anti-tumor immune response, and also tumor microvasculature damage. But generally, we want to give sub-local control rate, and also we want to widen the therapeutic window by delivering intentionally high doses within the tumor, but at the same time, with the use of, by delivering the low doses, we can spare the normal tissues surrounding the tumor. So this is an example of, usually when we have this kind of big tumor, these are the dose that we are going to plan and also deliver. So you can see the color is quite homogeneous because these are the homogeneous dose that I'm talking about. We usually deliver 20 gray of very homogeneous dose throughout the big tumor. But with the use of SFRT, okay, you can see that the whole tumor was covered by these 20 gray of doses, but within that tumor itself, okay, you can see some islands that were intentionally being planned delivering very high doses, okay? So when we plot a graph of the dose to the distant center, so you can see this dotted graph represent the dose distribution within the big tumor, but you can see this kind of graph when we plan using this SFRT technique. So you can see that this peak area delivering very high dose, and this valley area delivering very low doses, okay? So, and also quite to our shock, okay, actually this SFRT has been started way back in 1930s, Okay, but it was not called as SFRT. So it first called as the grid therapy, and being delivered using these perforated block areas, which was called as grid. So and as far as I know, usually this was used in US a lot, in the United States of America, and these are the kind of dose that were produced. But you can see that it does not, so the early SFRT technique, which is called as grid, is actually does not attempt to treat the whole tumor. It's actually only some part of the tumor that receive a certain amount of doses. Okay, so the clinical challenge is because heavy to use in daily practice, so you need to manually slot in the grid, okay? And also in terms of the, we as a medical physicist, there is an issue with the beam divergence in terms of the dosimetry. And also because these are a fixed diameter hole and spacing, so we do not know whether is it optimal enough? Is the spacing between these hole, is it optimal enough, or is the diameter of the hole is optimal enough to give a good response to the tumor? Okay, so with the advancement in the modern LINAC, now we have the MLC, what we call as a multi-leaf collimator. Okay, so with the use of MLC, you are able to move these in order to come up with a shape, with the similar shape like the grid one. So we are allowed nowadays to decide the hole size and also the separation between this hole. So these allow for better dosimetry calculation and also better dose distribution. Okay, so now if you have heard about IMRT just now, okay, so with the advancement in the dose calculation, okay, now with the use of IMRT, so from grid, now we called as lattice radiotherapy, but it is the same kind of SFRT, okay. So now with the use of lattice, you can see that the similar one, instead of the use of grid, you cannot deliver the whole dose to the whole tumor. So with this IMRT era, which we call as lattice, you can allow to deliver 20 gray to the whole tumor, and then in the center of the tumor, okay, you can increase the dose up to 60 to 90 gray. So it's quite substantial, significant different in terms of doses. Okay, so the principle in this lattice SFRT is to create multiple localized high dose small sphere. Okay, and at the same time keeping the value dose still to the 20 gray, because you can see that surrounding the tumor is the normal tissue. So we want to make sure it is safe for the normal tissue, okay, to receive some amount of doses, but we really want to kill what's inside the tumor. Okay, so the evolution of SFRT, starting from the conventional radiotherapy using the grid, okay, then goes to the lattice, and these are quite being actively in research, where they are looking at to come up with much more smaller, which they call as mini beam and also micro beam. Okay, so these two only being clinically used nowadays. Okay, so the radiobiology of SFRT is actually, it relates to the understanding of the anti-tumoral immune response, activation, bystander, or abscopal effect, and also because of high doses, it automatically create a quite significant vascular damage within the tumor. Okay, so so I think it's we have heard about this. Okay, so by delivering very peak doses and also valley doses, it actually allows the immune system to be stimulated, okay, and producing the release of tumor antigen material, which will go back into the tumor, and also it also will go to the distant tumor, okay. So also this enable recruitment of lymphatic immune cells to the tumor site. Okay, and also bystander effect also happen okay, in which the radiation-induced changes in cells that are not directly traversed by radiation but are adjacent to the irradiated cell. So these are something that the research are quite actively looking at this effect, and also some of the patients have shown have shown the similar effect in some of the clinical cases. And this relates to the steeper dose gradient between the smaller peak space and also this valley pace, which shows that the smaller survival fraction of tumor dose with the steeper dose gradient and smaller peak space. And this one is quite understandable. If you deliver quite high doses inside the tumor itself, it creates a vascular damage effect. So immediately post SFRT of tumor cell ablation from the peak dose, the tumor vascular changes occur. Okay, so this helps to increase the flow and sensitivity to the chemotherapy drugs recruitment in the tumor cells also. Okay, so you can see that these are the compilation of the earlier SFRT technique in 1990. This one started using the grid technique and up until 2021. Okay, so you can see that the dose is quite high. It is a single fraction, delivering 10 to 15 gray in only one single fraction. Then the trend is moving towards combining this single fraction with the number of fractionated radiotherapy. Okay, and you can see that now the combination of using the grid and also chemo and also fractionated radiotherapy, and also in some studies by combining also with the surgery. And the intention now also moving from palliative towards the curative intent. So we are not talking about palliative also. We are talking about application of SFRT in a curative setting. Okay, and I think the response rate that we can see for this kind of patient is more than 70%. Okay, with the acceptable toxicities. So these are the example of the one of the clinical case. So this patient have a fast-growing mass at the chest wall. So they treat her with single dose of 21 gray to the 98% of the D98 of 21 gray, and they can see that the tumor regress for about 78% post 1 month SFRT. Okay, so for case 2, the example is quite huge, as you can see. Okay, again 20 gray in one fraction, but this one is using the grid, not the lattice. So you can see that 1 month after the treatment, the tumor regressed quite significant. Okay. The third case is lattice treatment. Okay, but yeah, so you can see that the 2 months after the treatment also the regression is quite significant. But why SFRT remains largely unused? So we thought that if this technique has been developed since 1990, why it remains unused? And it's because most of our clinical dose tolerance related to normal toxicities comes from this MRMI and also contact data that comes from the conventional RT, whereas until today, there are no extensive dose-volume relationship for the use of SFRT. And we know the minimum tumor dose covering the tumor volume, okay? And this is quite, as a radiation oncology and also as a medical physicist or clinical oncology, we are very familiar that you need to deliver very homogeneous dose throughout the tumor. So when you introduce optimal peak and valley size, so the question comes in our mind, how high the dose that you can go, okay? So all this is quite unsure, and also again this is still under ongoing research to understand radiation-induced secondary effect. So all this in terms of the immuno response. So I would like to present our data, but we just started our SFRT technique the last 3 months, but to our surprise, we managed to treat 15 patients now. Okay, but so we thought that we are looking to sharing our outcome maybe in another 1 or 2 months or next year. Okay, so high dose SFRT has been clinically implemented. So although it is quite limited number, but you can see that the promising results is there. So extending beyond these conventional RT is actually, we need a better understanding of this SFRT mechanism. So we hope to see some of the future studies related to the dosimetry, radiobiology, and also clinical outcomes. Okay. Thank you.
Thank you, Doctor. So our last presentation, we will invite Professor Huang Chonggui, Director of Laboratory Medicine from Chang'an Memorial Hospital, specializing in genomic sequencing and molecular diagnostics.
Hi, good afternoon, everyone. I'm Chonggui Huang from Chang'an Memorial Hospital in Taiwan, and currently the Director of Laboratory Medicine and also Associate Professor in Chang'an University. And today I'm going to talk about the NGS application in cancer care. And in the field of cancer care, actually in 2016, there's a huge event really changed the history of NGS treatment because the former US President Obama announced the Cancer Moonshot program. And the goal of this program is to accelerate the cancer research and make more therapies available and improve prevention and detection. So for the Moonshot program, using the NGS technique to do all the cancer tests and surveillance. Actually, the people found, actually that Taiwan also joined, is also part of the Moonshot program. So we all work together, and all the scientific collaboration and data sharing is the most important part of this program. So all the data were analyzed by NGS, and also we share the database and together. So after the Moonshot program, so it increased a huge amount of NGS data for the cancer patient. So after that, recently, actually the next generation sequence is widely applied in the clinical service. Okay, so in the past, usually we do one gene for cancer at one time, but now we did have a lot of improvement in the next generation sequence technique. So we can do a huge amount of cancer genomic sequence at one time. So we can actually to provide the right treatment for the right patient at the right time. And it's all due to that we have the help from the genomic data. So you can see right now we can sequence hundreds, actually millions of genetic sequence for the cancer patient in one time. So the improvement of the next generation sequence technique is the core engine for the improvement of NGS. So it's very high throughput and high efficiency, and right now it's cost effective. So because it's cost effective enough right now, so it can be applied in the clinical service for the patient. And actually, after the next generation sequence, it really allows us to view the complete genetic landscape of the tumor with unprecedented breadth and depth. Right now, for the NGS application in cancer, I will talk about the diagnosis, treatment, and follow-up. For the diagnosis is to establish the cornerstone of treatment. For the treatment is to help the patient to find the most suitable target drug for each patient. And for the, also we can, because it's very sensitive, so it can be applied in the follow-up for the patient, so we can monitor the disease progression and drug resistance in real time during the treatment of the patient. So for the diagnosis, because we can use the NGS technique to provide a comprehensive genomic profiling at one time. Even for the cancer genomic detection, we can identify the gene fusion, single nucleotide polymorphism, or copy number variation, or the insertion or deletion of the gene. So we can have the definitive disease diagnosis for each patient, and also for some we can also have the prognosis evaluation for the patient. So like if the patient have the TP53 mutation, it seems that it's very aggressive cancer disease. So the prognosis might be not that good. And for the diagnosis part, also there's one part of the cancer we should pay attention is about the inherited cancer. Using for the inherited cancer patient, we can help the NGS genomic panel can be used for germline testing to detect the inheritable oncogene mutations. So for the family have the history of cancer, we can help them to identify the high-risk individuals and establish the personalized intensive screening plans. So it's better that we can help the patient if they can identify that they did inherited the oncogenes. So maybe they should have more intensive screening plans to help them to do some preventive action and to cure the disease as soon as possible. So for the inherited cancer, I think it's also very important to provide a family genetic counseling. It's also an important part for the inherited cancer diagnosis because some people may be in bad mood if they were diagnosed to carry the oncogene. Okay, for the treatment part, right now, the primary application of NGS in treatment selection is to identify the actionable mutations. So if we identify the gene mutations that can serve as the drug targets, and so these mutations are the key drivers of cancer growth and survival. So we use the target, identify the target therapy for each patient. And also, in a treatment, we can predict the immunotherapy efficacy because in the NGS data, we can also provide the tumor mutation burden and the microsatellite instability data. So if for the patient with high tumor mutation burden, then the patient will be have better efficacy during the immunotherapy. And right now, we also can apply the next generation sequence to do the monitoring. And we can have the blood specimen, like it's called the liquid biopsy. So the liquid biopsy is a very non-invasive testing method that can obtain for each patient. So the patient only have to draw the blood, and then we can use the NGS technique to detect the circulation tumor DNA in their blood. So it can help us to understand also can help the patient to have the treatment selection and to monitor if there's a drug resistance occur during the treatment. And also after the treatment complete, we can also continuous monitor if there's some reoccurrence occurs. So it's minimal residual disease monitor. So this all because of the high sensitivity of the next generation sequence can help our patient. So we can use the NGS technique to follow up treatment and to to monitor if there's a minimal residual disease occurred. So it's very important for the cancer patient during the treatment. So right now, after the previous introduction, I will show some lab procedure and clinical case in our hospital. And our medical laboratory is the CAP accredited laboratory since 2003. It means that every data from our laboratory meets the international standard. So we also welcome all the clinical trial collaboration with us. So we have plenty of panel for the genetic testing, including genetic disease or paternity tests, and also, of course, the cancer companion diagnosis and the comprehensive NGS program is included. And we provide the most genetic tests in Taiwan, and we have more than 100 precision medicine tests in cancer, in the field of cancer, genetic or reproduction. So for the oncology, we provide 30 items. Right now, NGS comprehensive cancer panel is the most important one for cancer patient. And in 2024, we provide more than 9,000 service in 1 year. So for the comprehensive cancer diagnosis for NGS, right now we use the most powerful platform nowadays. We use the Illumina comprehensive platform. It can detect 523 genes at one time. So right now, for the comprehensive cancer surveillance, there are many platforms available. For the platform, over 100 targets is so-called the comprehensive platform. But I think it's very important to provide in Chang'an Medical Foundation, we choose this 500 platform because it can provide the most complete information for the cancer genetic test. Actually, the laboratory processing days for the NGS is about 5 days in lab, and also 2 days for the report. So actually, if we get this, usually we start to perform the NGS process on Tuesday, and then we can complete the whole wet lab process on Sunday. So we can start to have the dry lab analysis on Monday and get the report. So you can see from the list that the TrueSight 500 system have the most comprehensive genetic profiling, also including the NTRK and the pan-cancer gene, and also the tumor mutation burden and microsatellite instability test. And there are some target genes for each cancer. So in this platform, actually 100% covered for the key guidelines by cancer types. And this is the target therapy list for lung cancer. So for each gene, there are lots of target therapy available drugs. And also for the inherited cancer, we recommend to use a whole genome sequence service to help the patient. So right now, there are about 19 cancers. There are some family inherited oncogenes. So we have designed the whole genome sequence panel to help the patients. So also after the clinical evaluation, to make sure about to elucidate the family history, then maybe the patient and their family members can draw the blood and to do the whole genome sequence together. Okay. And so for the next generation sequence, it's very important that not only the the work from our lab team is enough. We have to collaborate, to work together with the medical consultant team. So we have a strong lab team, and also we have a dry lab bioinformatics. And our data, after we complete our data, we will have the medical consulting work together to discuss the importance of the result and to have the right prescription of the target therapy drug. So it's very important that our doctors is also very expert in this field, so they can apply our NGS data very for the patient. And next, I will show us two cases that in our lab, in our hospital. So we have the molecular tumor board meeting every month. And for the molecular tumor board meeting, the medical lab staff and our pathology department members and also our clinical doctors, we all work together and to discuss the case. So the first case is a restaurant chef, a 47-year-old restaurant chef, and she have a neck mass found. And I think at the first time he has completed the NGS data, and we can see that for this patient, he did has a very complicated genetic mutation in his cancer. So this case really have a complicated therapy process. And after 2 years treatment, he did another NGS data and also find a lot of complicated genetic mutation. And we also can, because the NGS data, we can calculate the percentage of each mutation. So we can know the change of his cancer genetic mutation during the treatment process. And the second case is a brain tumor case. This is a 32-year-old female patient, and he had removed the brain tumor and do the NGS. And for the NGS data, it also revealed that the case has more than one tumor mutation, including the FGFR1 and LZTR1 mutation. The FGFR1 is the tier 1A mutation, so it can have the drug treatment. And from the data, we also find that the tumor mutation burden is low. So it means that the patient predicts that might have a poor response to immunotherapy. So from the result of these two patients, you can see that it's important that we can provide the most comprehensive data for the patient at the very first beginning of the treatment. I think it's very important so for the patient to, for the doctors to know the condition of the patient at the very first time. And right now, for last 2 years, actually we switched to the TrueSight 500 system for about 2 years. And for these 2 years, we have complete 1,600 patients. And for the data, we can see that the median age for the cancer is around 60 years old, but the mean average age is 58 years. And the gender distribution, 58% is female, and around 60% is female, 40% male. And the top 10 cancer list, the first one is lung cancer, about 900 cases, and colorectal cancer, liver, brain cancers. And also the top 15 mutated gene is EGFR, KRAS, and PIK3CA genes. And some patients have the copy number variation. So the top 3 genes for the copy number variation genes is the MYC, EGFR, and CDK4. And also from the data, we can also we identify that many patients they have a co-occurrence mutation. So we can see that the EGFR mutation might co-occurrence with KRAS, PIK3, BRAF, or TP53. And also the copy number variation and mutation also will happen together. So about 30% of patients, is about 465 cases. They have both the copy number variation and the gene mutation happen together. But most patients is for the mutation part is about 48%. And also from the powerful NGS platform, we can help the patient to identify the actionable genes that they can find the proper target drug for their therapy. So for the EGFR mutations, around 25% patient can find the target therapy. And for the copy number variation, about 35 patients can have the target therapy available. So, and overall, for each cancer type, that we can see that for the pancreas cancer, 91.9% patient, they can have the mutation detection and have the actionable target for the patient. And for the brain tumor and liver and lung, it's about 80% of patients can benefit from the NGS data. So in conclusion, actually the genetic mutation can be detected in 87% of our cancer patients, and the mutation detection rate is quite high. So through the comprehensive genomic profiling by NGS can provide valuable information for the patient, for the diagnosis, treatment, and follow-up of our patient. Okay, thank you for your attention.
Thank you, Professor Huang. And this brings us to the conclusion of today's forum. Thank you all for your participation. And we look forward to seeing you at future events.